Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier Education brought to you at no cost thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. I'm Eric Lim, and this week it's a great delight for me to present Professor Anna Novak, who was the chair of TNM9, to update us about the new changes for the staging for mesothelioma. Anna, over to you.
Thank you, Eric, and hello, everybody. It is very strange to be presenting without being able to see anybody, but I shall do my best. My name is Anna Novak. I'm a medical oncologist, particularly specialising in mesothelioma over the course of my career, and a researcher in tumour immunology and mesothelioma imaging. But in my present role as Deputy Vice Chancellor Research at the University of Western Australia, I'm actually no longer doing clinical practice, but I am continuing to work in the mesothelioma staging. So my brief was to talk to you a little about the 9th edition TNM staging, and I want to start by acknowledging the very many people who were an important part of this and who we spent every second week an hour or so together as we progress towards the pointy end of this. So particularly acknowledging Valerie Rush, Rita Gill, Andrea Billet and Hedy Kindler as the leads of the particular areas that we'll be talking about today, and also the CRAB biostatisticians. So mesothelioma had quite a slow start in terms of evidence-based staging. The first staging systems were proposed through surgical databases, and these were just accepted straight up into the 6th and 7th editions of the UICC, AJCC staging manuals. And they were very heavily reliant on surgical findings, so quite difficult to extrapolate through to clinical findings, particularly when we consider that worldwide, most patients with mesothelioma don't actually go through mesothelioma surgery. So that first prospective data collection sponsored by the ISLC started in 2011 with an electronic data capture database, and also taking cases from some surgical series. And as part of the preparatory work to this, there were workshops that looked at adding unidimensional measurements of tumour thickness, because as you know, most staging systems do actually incorporate some form of measurement that estimates the bulk of the tumour, and that in many cancers that is an important part of prognostication. So that first iteration added unidimensional measurements of tumour thickness to explore that, and demonstrated that it may well have a role. So although the 8th edition did not add tumour measurements as part of the staging system, we were progressing towards that. And for the 9th edition, we had 3,519, sorry, that should be the 8th edition, 3,519 patients from 29 centres. And the result of that was a revision of N descriptors, going from a N0, 1, 2 and 3 classification to a simpler classification of N0, 1 and 2 that was evidence-based on the basis that we found no discrimination between the original N0, N1 and N2, so they were combined. The database has grown over the 3 iterations, and the 7th edition there were 2,300 or so submitted, but the 8th edition 2,460 and the 9th edition 3,481 for the largest collection of mesothelioma cases for staging. And the treatment time frame that we are talking about for this one was between 2013 and 2022. That should be diagnosis time frame. With, as you can see on the right-hand column, a progressively smaller proportion of patients in each iteration actually being patients treated with curative intent surgery, which reflects the greater emphasis towards collecting clinical cases that reflect what happens over the full spectrum of mesothelioma. So in the 9th edition, we expanded the data elements to include that measurement of pleural thickness, updated the nomenclature for surgical procedures, and added a number of molecular markers. We ended up with cases from Europe, Australia, Asia, North America, and South America, quite reflective of our mesothelioma population, with a median age of 71 and majority being men. There were some key questions for this 9th edition, what we were looking at to make changes to the staging, as long as they were evidence-based and our hypotheses were confirmed. We wanted to understand whether quantitative pleural thickness measurements could add to or replace existing qualitative T descriptors for clinical T staging. We want to understand if we needed to further nuance N descriptors, and whether there were some categories for M1, for example, extrathoracic or intrathoracic, one or more than one lesion in an organ, and other different ways of analysing the possible subsets of M descriptors. Also, of course, to do an evidence-based exploration of how the stage groups were created, and those exploratory analyses of molecular alterations, which I won't have time to talk about today. If this is the one slide that you look at, this is everything in one. It is the all stages paper graphical abstract from the final publication, and I'll work through towards this over the course of the talk, but basically we have ended up with groupings that provide a greater amount of separation and discrimination than we have ever seen before for clinical staging of mesothelioma. The one that we have very little separation here, 3B and 4, a lot of discussion about that, but of course in line with the general nomenclature in staging that stage 4 is equivalent to M1, we did elect to must have M1. We did elect to keep stage 3B and 4 separate. And I will come later to the differences between the proposed groupings and the key changes, but this is really where we landed. In terms of how we got there, well, I have talked already about most of these, but this just gives you a quick visual of where the patients came from: North America, Europe, and Asia predominantly. Most of you will be familiar with how we make these quantitative CT image assessments. So the principle underlying this was that it had to be straightforward. We had to be able to have either a radiologist or a clinician do this without adding too much complexity into the measurement. We had to make sure that it was applicable everywhere worldwide, irrespective of the sort of quality of CT imaging and whether or not there was volumetric software available. And we know that volumetric software is always improving, but it's just not available for mesothelioma everywhere. So the thorax, the hemithorax was divided basically into, and these lines are probably a little high, the top of the arch of the aorta, the top of the right atrium. And so we had an upper, middle, and lower hemithorax. And in each of those nominal thirds of the hemithorax, a single measurement of the maximum pleural thickness in that area of the hemithorax was taken perpendicular from the chest wall or mediastinum. So see here, we've got 17.7. This is the largest perpendicular measurement of a mass in the second third, 31.8 millimeters. Down at the base, it can get quite challenging to take an accurate measurement. You don't want to go too low and run into the diaphragm, but here again, perpendicular to the mediastinum. And the sum of these is the sum of pleural thickness measurements, which is called P-sum, and in this one, 90.4 millimeters. The second measurement that's taken is a measurement of the pleural thickness in the fissure that is taken on sagittal images, and that again is what is the maximum thickness of fissural involvement. And that is not added to the P-sum, but it becomes important in breaking down the T descriptors. From the database, the CRAB statisticians used recursive partitioning analysis along predetermined data-driven cut points. And what I've shown here is this here is the difference between a low P-sum and whether the fissure is involved, that's labelled here as medium T, or the fissure is not involved. And so what we identified was that in fact, the survival, whether you had a larger P-sum, which is in this particular analysis was above 12.2 millimeters, or that smaller P-sum below 12.2 millimeters, but with the fissure involved, the median survival was very similar between those. So we went through very many analyses with the CRAB statisticians to identify the best and most robust groupings across the data sets. And this just illustrates how we reached the 4 different T descriptors. So when we talk about the T descriptors, we've moved from pathological T and those descriptors that were actually applied or attempted to be applied in the clinical setting with imaging alone. And clearly, when we're talking about tumour limited to the ipsilateral pleura with no involvement of the fissure, well, we can do reasonably well with that. But when we're asking about levels of invasion that are seen on CT of structures which can be really quite difficult to identify on imaging, this is where the clinical staging was falling down. So what we have landed on is T1 with the sum of those pleural measurements being less than or equal to 12 millimeters without involvement of the fissure. And fissural involvement is defined as greater than 5 millimeters. So to allow for other artifacts of the imaging or fissural scarring, this was taken as the cut point, and that was also driven by the analyses. T2, involvement of the fissure as the, involvement of the pleura with P-sum going up to the next size grouping, which is between 12 millimeters and 30 millimeters. Or, as you saw in that earlier recursive partitioning analysis, could actually have a lower P-sum. However, it had fissural involvement or mediastinal fat invasion or a solitary area of chest wall invasion. For T3, we're looking at that P-sum being greater than 30 millimeters and with involvement of one or more of the following. So I'll just turn off somebody's teamsing me. And then T4, we move away from the requirement for measurements because the involvement of any chest wall bony invasion, mediastinal organ involvement, or diffuse chest wall involvement that through the diaphragm or pericardium was such prognostic importance that it overrode any size of pleural thickness. But what's key here is that the pathological T is essentially unchanged from the previous iteration. So we are asking people to consider two quite different ways of T staging, one using imaging and measurements and the other using organ involvement in a way that's not been done before in mesothelioma. So this is another illustration of how we can get to T1, a very small, less than 12 millimeters. These are situations where you might have a couple of tiny nodules that you see in one area of the pleura, and the rest of the pleura may actually be uninvolved. The fissure does not appear to be involved, and this is a T1. And I do want to acknowledge Professor Ritu Gill, my colleague, and we have a manuscript in press that is going through some more detail on how to do the T imaging, the T staging. This is an example of a patient with this relatively well circumscribed single tumour mass, not involving the fissure. So this one would have been Fmax at 0. And however, that area on perpendicular to the chest wall did measure more than 12 millimeters. So this put this patient into T2. Next one, really quite a substantial area of basal tumour involvement, but also seen in the upper and middle hemithorax to some extent. Importantly, CT imaging in a way that allows any pleural effusion to be distinguished from any pleural thickening is important if there is a pleural effusion in situ, so the timing of contrast and delays becomes relevant. And so this patient had a P-sum of 40 millimeters, so it was over that 30 millimeter cutoff that brings into T3, but they had no other invasion in a way that would push it up to T4. And the final one, although the tumour bulk is actually quite small and probably would have made it into T2 or T3 had that been the only consideration. Here we have a tumour that is destroying a rib and therefore becomes a T4 tumour. So when we look at the 8th edition versus the 9th edition, acknowledging that the 8th edition used those descriptors of the involvement of organs or chest structures, we can see that here T2 and T3 really overlapped very closely, but when we get to the right-hand graph, when we are using the measurement for clinical descriptors, we see much better separation between these curves, including separation between T2 and T3. So moving on to the N category, and I'm not going to say a whole lot about this because this change was made previously. Into N0, N1 and N2 and removing N3 from consideration. That held up in this next edition, and you can see the the implications of moving from N0 to N1 and N2. It also held up with pathological N, and the reason, of course, we don't have any N2 here is that we had very, very small numbers of resected patients that had any N2 involvement, because, of course, if they were to have had supraclavicular nodes, for example, they would generally not be considered a surgical candidate. So it's good to know that we're resecting as a mesothelioma community those that are appropriate to be resected. And again, a small difference in survival between N0 and N1 pathologically. There were a number of different analyses done to understand if other nuances such as single versus multiple stations, for example, were important. And in fact, we found that for N1A single station or N1B as analysed multiple stations, we didn't find that that was able to discriminate survival outcomes. So because of that, we have left it as simple as N0, N1 and N2. Similarly, for M descriptors, we did a number of additional analyses to understand, as I alluded to earlier, might there be an overall survival difference depending on whether you have intrathoracic metastases, for example, to the contralateral lung, or extrathoracic metastases. And the numbers are really quite small in terms of the numbers of patients who have metastatic disease at diagnosis of mesothelioma. So we're really only looking at 228 patients overall. And that number came down even more to 158 when we were looking at those that had the level of confirmed detail that we needed on intrathoracic and extrathoracic. But there was no difference in this analysis. And one of the things we need for the next analysis is greater numbers of participants who have metastatic disease at diagnosis to help us do these analyses. When it comes to then exploring the stage groupings, because we always have a larger proportion of patients that may have all of T, all of N, and all of M information, but we do get down to smaller numbers when we are looking at those participants that have the full suite of information that we can use for the stage grouping. So whilst we may have started out with nearly 3,600 patients, in the end, we get down to a smaller number of just under 2,000 that we can use for clinical stage, and around 450 that we can use for pathological stage. So that brings in additional limitations to the data set. Now, the final stage groupings that we have, you can see through this table on the right, really in terms of separating the survival curves for those stage groupings. The only one that fitted into the best survival was T1N0. Clearly quite a small group of patients, only 125 in the database as a whole. And indeed for stage 2, with the next best survival outcomes, only T2N0 and T1N1 fitted into that. We then go to a large group of the patients that end up as 3A, with a very consistent median survival, with every which way we cut that, we got to around 21 months for those patients who were T3N0 or T3N1 or T2N1 or 2, and even T1 N2. So we've got this very large bulk of patients here, which is all of T3, most of N2, and the N1 T2. And clearly this makes up almost half of all of our patients will be stage 3A. And any patients with T4, so again, getting back to the organ chest wall invasion, put them very close to stage 4, and they have all been categorised as stage 3B, irrespective of the nodal involvement. And I haven't got the M1 here, but you can see it in grey on the figure. So when we look at those changes, we have removed, well, I guess you can say we've simplified things. We've removed 1A and 1B, and in some cases we saw such a very significant survival difference, for example, between what had been classified 1B in the past, according to T2 or T3, and what is now either T2 or T3A. This is all in the publications that have been referenced on previous slides as well. Of course, we haven't had as many changes to 3B. Most of what was in 3B remains in 3B. So stage 1A and 1B merged into stage 1. Only T1, N1, N0, M0 now classified as stage 1. All T3 is stage 3A, and all T4 still classified as 3B. There are some limitations. We're still seeing a larger proportion of surgical cases added to this because of the great rigour with which surgeons and pathologists document their findings for staging, and because we did still accept some institutional staging databases, but increasing the proportion of clinically staged to more closely reflect clinical practice. There are really quite small subsets of cases with some of the information, and examples of that, any PET data really, let alone SUV max data, and again, small M1 and subsets of M. The molecular and other prognostic indicators have been dealt with in another manuscript, and I really don't have time to talk about that today, but it is quite inconsistent in terms of the techniques that are used and the cutoffs that are used. So this is something that we'll be seeking to standardise and collect more data in the next edition. And of course, most of these cases predate our contemporary treatment, and most cases are submitted from centres of excellence or high volume centres. So do they reflect the survival that we see in the community elsewhere? We're not quite sure. This next iteration, we're currently finalising the protocol and the data fields, and the aims are to validate those findings from the 9th edition, but also to assess the prognostic impact of some of the new predictors which were started to be explored in the last iteration. T thickness from the diaphragm as a vertical measurement is something that some of our radiologists are quite interested in. And again, seeing if we have more participant numbers so that we can look in more detail at the number and site of involved lymph node stations and extranethrothoracic metastatic disease. Prognostic impact of a number of pathological factors. Clearly, there's a lot of interest in PD-L1, but I personally have some concerns about the different platforms and the different cutoffs that may be reflected, at least in this next data set, as the field stands at the moment, and some other specific tumour somatic pathogenic aberrations. I'm going to finish bang on time with a little advertisement for the IMIG 2025 meeting, which is being held in October 26th to 29th. It's the International Mesothelioma Interest Group. It is shaping up to be a fantastic meeting. Abstract submission is, if not open at the moment, open very soon, and really hope that we will see some people from the UK, from the Brompton, joining us at IMIG in Philadelphia. Thank you.
Thank you very much, Anna. A fantastic presentation. We've got lots of questions from the audience. The first question probably from Dr. Chevu, who's asking, where exactly do you do the lines when you're measuring P-sum? And I think the apex is easy because the apex is always the apex, but it's the diaphragm area that's difficult. Is it the dome of the diaphragm, the left or the right recess? Where's the bottom line of the measurement for the thirds?
It is very difficult, and I think what we have to bear in mind is the curvature of the diaphragm and the anatomy. It's not, and I think nor does it need to be, an exact science for this. We're getting a gestalt, we're getting an estimate of how much pleural thickness there is. It is, so if you know, what you want to be ensuring through probably looking at some sagittal and coronal as well is that you're actually taking tumour thickness. You're not going into a slice that on an axial plane that is actually reflective of the tumour that is coming up across the diaphragm. So in those very basal ones, you may need to look at a few different planes to be able to be confident that you're getting a true perpendicular maximum thickness.
Thank you. Dr. Obadiah is asking, you know, the measurements are generally undertaken in a two-dimensional plane. How about tumors where you have a coronal section which is quite thin, but when you use axial, you get much thicker sections along the back wall of the three-dimensionality of the hemithorax? How do you account for that?
Yeah, so look, axial gives us the most nuanced, well, the most ability to see everything in one plane as we work down through the hemithorax. So we are asking for these to be taken axially. I hope that helps. Not quite sure that I understand the question entirely.
Done. Question from Al Bulushi is, does the thickness slice of a CT matter when we are estimating P-sum?
So we suggest that the thickness slice is no more than 5 millimeters. But in contemporary CTs, they will usually be much, much less than that. I don't necessarily need to go to the finest resolution slices that the radiologists are using. Whatever is presented for clinical use in the clinic will be adequate. But yes, most CTs will now have slices of 1 millimeter or less.
Thank you. Dr. Therese is asking about 3D reconstructions and the actual volumetric analysis, and maybe for you to explain a bit about the difficulties. Was it just because most centers didn't have the data, or was it difficulty to standardize volumetric data across the world?
Well, a bit of both, to be honest. So most centers, it would take away from the oncologist or surgeon being able to submit the data if they needed to, for starters. But there are different softwares and they have not as yet been validated one against the other to understand the extent to which there is concordance between the different radiological and manufacturer softwares around volumetric imaging of mesothelioma. The challenge with mesothelioma is it is often discontinuous. So having a software that is able to distinguish also between reliably distinguish between some of the chest wall soft tissues or pleural fluid or some loculated pleural fluid, or incorporate the fissure. As a whole mesothelioma imaging community, we haven't got consensus on what the optimal way of and the optimal software for measuring mesothelioma volume is. I hope that colleagues like Rita Gill, some of whose images were shown here, I know that people like Rita Gill and Sam Armato are continuing to work towards that, and others in the UK as well. But understanding even the performance of how does one software package relate to another in terms of the volumes that they come out with, we don't have that understanding yet.
Last question from Dr. Srinivasan, who's asking if the pleural thickness matters, if it's lateral wall or mediastinal aspect. Is it just a thickness that's taken?
Yeah, that's a good question, and we're not collecting where it was, so don't know the answer to that. But I think it's actually a really good question, and maybe we should make some effort to collect it. That would add a lot of complexity, because we're not collecting the images as such, and they're not being centrally measured. This is all investigator submitted, and of course, it would be difficult to, I guess arguably, invasion could become more important in the mediastinal areas than it might be in the chest wall areas as a contributor. So yeah, great question, but not one we're equipped to answer.
Well, thank you so much. Your talk is so engaging, and everybody's like asking so many questions. We never have enough time to be able to answer all of them. And clearly, you've really inspired the entire audience today. So thank you very much. Next week, we've got Andrew Nicholson talking to us about an update on mesothelioma with the paper he wrote on behalf of the ISLC. The IMIG is going to be, I think, a fantastic event, and I hope that many of us will be able to join you in Philadelphia to understand and learn lots more about mesothelioma, which remains me to thank our sponsors, AstraZeneca and Medtronic, and also Medela, the Science of Care, to thank you for your leadership, Anna, for chairing the TNM9 Mesothelioma Staging Committee and advancing the science across the world. Thank you so much for your talk today.
Thank you, Eric, and thank you and goodbye, everybody.
Bye-bye.